Good morning, everyone. Good morning. It is my extremely great pleasure to formally open HCH 2023. We've already had a great day yesterday. For those of you who were at the pre-conference institutes, they were simply spectacular. And I'm glad to say we have more than 1,000 people registered. And this is the second year in a row that we have sold out. So that shows the interest in our community, not only of learning from each other, but also of just getting together, being with each other's presence, and just, we just love each other. So it's just wonderful to be here. So we're going to hear some videoed remarks from our board president, Amy Grissett, and immediately after that, we will have a land acknowledgement led by the former chair of the National Consumer Advisory Board, Art Rios Sr. So let's listen to Amy. If we're having
from Worcester, Massachusetts. My name is Amy Grissett. I am a former chair of the National Consumer Advisory Board, otherwise known as NCAB, and I am the current president of the Council's Board of Directors. Welcome to Baltimore and the Healthcare for the Homeless Conference. I am not able to be there with all of you this year, and that is the first time in 19 years that I will not be attending. But I am so happy to be able to join you in this way. For those of you who are coming to the conference for the first time, I am so excited for you. You will have the opportunities to meet new people, to network, and attend amazing workshops. I encourage you to go to workshops that are of interest to you, and the great poster sessions, the awards ceremony, hill visits, site tours, learning labs, and especially our annual social justice rally that will take place Wednesday evening. There will be many people and lots to do. Please remember to take care of yourself. Enjoy this wonderful experience. I know once it's over, you will want to attend the conference again. Thank you.
Good morning, everyone. Once again, my name is Art Rios Sr., and I do this every year. I'd like everybody to stop eating for one moment, and let's do a moment of silence for those who have passed. Hey, thank you. So I'm going to be reading today's land and labor acknowledgement. But I'm going to say a couple things before I do that. This year when I got here, I was called upon to do this, and I hit a writer's block. And literally within the last 10 minutes before this happened, I wrote the last piece because I knew it was going to be a little controversial for a lot of different people, but I checked in with an elder and he said, do it. So the last piece may be controversial for some people, but I feel that it comes from me and what this land acknowledgement is. We will recognize today, Tuesday, May 16th, that in Baltimore City has the presence of more than 7,000 indigenous people. As we gather today, I will, and hopefully you will, honor them here in this city. Piscataway, Lumbee, and the Eastern Band of Cherokee community members. I want to honor and recognize indigenous people of our homelands. That the land has been built by other humans and given thanks to all tribal nations as we gather from all over the world and the United States here at this conference. We also acknowledge the labor of enslaved African, Chinese, Japanese, and Jewish, and all cultures and descendants who worked this stolen land for the colonists who continue to disproportion and face economic oppression, racism, violence, and exploitation. I am a person with lived experience, and someone just taught me that I am a person now of a lived expert. Thank you.
Thank you very much, Art Rio Sr. We appreciate that, and appreciate the inspiration coming at the last minute and you being able to share that with us. So I mentioned that we have over 1,000 people, and just want to say we have people here from 49 states, 3 territories, and at least 2 foreign countries, which is really, really tremendous. And we're going to hear in a little bit from our keynote speaker, who is from Canada, our dear neighbor to the north. So before hearing from him, I'd like you to join me in thanking our sponsors that have helped to make this wonderful conference possible. Our platinum sponsor is California Healthcare Foundation. Gold sponsors are United Healthcare Community and State and the United Health Foundation. Bronze sponsor is Ecovia. Let's give them a round of applause. And we're also grateful for our exhibitors, and I hope that you will go visit their tables and learn more about their services. So, Center for Medicare and Medicaid Services, also known as CMS, First Nonprofit, which is sponsoring the the conference Wi-Fi for today, Gilvar Consulting, Housing First University, the HUD's Office of Policy Development and Research, Life Startup Essentials, and Montefiore Einstein from the Bronx. And just as an aside, all 3 of my children were born in Montefiore hospitals. So let's give our exhibitors a round of applause and show them their support by visiting and learning about them. I also want to thank some of our staff. As I've said before, I've been coming to this conference as a member of an organization for more than 20 years. And when I joined the staff 6 years ago and saw the behind-the-scenes work of what it takes to make this conference possible, it is just really amazing. It is an all-hands-on-deck for at least 9 months preceding the conference. So I really just want to thank all of our staff who have worked hard and tireless to make this possible. Let's give the staff a hand. And among all the staff working really hard, just also want to especially give thanks to Brett Poe, who many of you have interacted with, our event manager, Kim Chiaramonte, who is the senior project manager for our Vaccine Ambassador program, and then pitched in to help secure our sponsors. So really grateful for her. And yes. And also Chelsea Hardin-Hensley, who many of you may have interacted with, also working on the Vaccine Ambassador program, and also pitched in to help make sure our membership was straight. For those of you who are members, as you know, you got a substantial discount, so we wanted to make sure that was clear, and Chelsea helped to make that possible. So thank you. I just want to say a couple words about our theme. Our theme is Toward Justice, leading with lived expertise. And you'll see signs around. We also wanted to commemorate, we chose that theme in mind because this is the 20th anniversary of the National Consumer Advisory Board. Yay! And consumers is our term for those who have been patients in healthcare for the homeless programs, people with the lived expertise of homelessness. And we know that we can't really have justice unless we are listening to those who have the lived expertise, those whom our programs are attempting to serve. We can have compassion without listening to them and letting them be involved in the decision-making process of how our services are formed, but that's not really justice. Justice is really what I've heard someone say, and I like to use this a lot. I don't know who said it, so I can't give them credit, but justice is what love looks like in action. It is treating others the way that we would want to be treated, regardless of our life circumstances. If we didn't have the advantages that we have, if we had more troubles than we currently have, or when we've made mistakes, justice is how we would want to be treated. And it's not just on an individual level. We want justice at a society level so that our societal response is motivated by love, how we would want to be treated regardless of the situation in which we find ourselves. So we are so grateful for those with the lived expertise that for the last 20 years have been walking aside the council and working with us. And we'll say a few more remarks about our NCAB throughout the conference. One of the people who next we'll hear from is Jeff Olivet, who many of us know. He's been at this conference for many, many years. He's been a presenter at this conference, has a healthcare for the homeless background, and he has been one of the leaders in helping to make sure that we are lifting up the voice of people with the lived expertise. Jeff is now the Executive Director of the United States Interagency Council on Homelessness, and we're so grateful that he is able to be with us here today for some remarks. Jeff?
Good morning. Wow. Good morning. It is so good to be here with you all. Being at this conference with so many of you over the last 25 years has been an incredible source of strength and connection for me since I joined the Healthcare for the Homeless movement in 1998 as a street outreach worker at Albuquerque Healthcare for the Homeless. For me, 25 years in this movement also means that I've known Bobby Watts for nearly half my life. And there's one thing I don't quite get, and that's how after all this time I've got so much gray in my beard, and Bobby, you look just as youthful and vibrant as you did the day we met. And NCAB, the National Consumer Advisory Board, is 20 years old. And what an extraordinary impact you all have had, not only in shaping the HCH movement, but in shaping the entire national discourse on homelessness by raising the voices, wisdom, and deep expertise of those with lived experience of homelessness. Your strength and resolve continues to strengthen us all. 20 years, that means it's been almost 2 decades since I first met Amy Gressette and Joseph Benson. 20 years means that it's been almost 2 decades since I was with Amy and with Cowboy and so many of our friends from Boston HCH, as together we mourned the passing of Ellen Daly at her funeral in 2006. One thing we know from decades of HCH work is that homelessness is deadly. Every year, far too many of our brothers and sisters die without homes. And every year, far too many of us read their names and light candles to remember them on the longest night of the year. I'd like to commend you all for your life-saving work, the work that you do every day, and I'd like to commend the Council and NCAB for your great leadership in shining a light on the mortality associated with homelessness. When I joined the Biden-Harris administration almost a year and a half ago, I brought with me a deep belief that was cultivated in rooms just like this one, that homelessness is a life and death public health crisis, and that to solve it, we must bring the same urgency, creativity, and compassion that we bring to any life and death public health crisis, whether it's a hurricane, a wildfire, a flood, or a global pandemic. I also brought a deep belief that homelessness is solvable. The HCH movement taught me that housing is healthcare. I believed it when I first heard that phrase 20 years ago, and I still believe it today. I also believe, Barbara stuck this pin on me right before I walked up here. I also believe that healthcare is a human right. It was in this context that our amazing team at the U.S. Interagency Council on Homelessness developed All In, the federal strategic plan to prevent and end homelessness, which we released in December. All In strives for racial justice, acknowledging that homelessness disproportionately impacts people of color and that that's no accident. The plan centers the voice and the power of people with lived experience, knowing that only when people with lived experience are in leadership can we achieve meaningful and sustainable solutions. And the plan goes upstream to prevent homelessness before it starts. To do that, we need to make sure that health systems are at the table, along with child welfare, education, criminal justice, behavioral health, and all the other systems that have a critical role to play in identifying risk of homelessness and ensuring that housing subsidies and wraparound supports are in place to stabilize people before the point of crisis. This administration has committed to the work of ending homelessness not just with words on a page, but also with resources to back them up. Building on the historic investments of the last 2 years, the President's budget for fiscal year 24 includes $22 billion in mandatory spending to guarantee housing vouchers for youth aging out of foster care and for extremely low-income veterans. The plan also includes strategies to expand housing choice vouchers to 130,000 additional households. Now, we know that these strategies are only part of the picture, but taken together, these proposals would create a pathway to finishing the work of ending veteran homelessness and ensuring that no young person, most of whom are youth of color and LGBTQ, that no young person ages out of foster care into homelessness. Now, in the process of implementing these targeted strategies, we hope to show that universal housing vouchers are possible. The President's budget also proposes a 64% increase to the PATH program to ensure outreach to people with mental illness who are experiencing homelessness, and we're also proposing a 23% increase in resources for folks right here in this room, Healthcare for the Homeless projects. The President's budget is now on Capitol Hill, 40 miles down the road, and I am asking you right now to let your senators and your congresspeople know how transformative these investments would be and how badly they are needed. We also need HCH programs at the table in communities across the country that are struggling to address the crisis of unsheltered homelessness and encampments. I believe that communities can and should address encampments head-on, and that the most humane and effective way to do it is through public health, not law enforcement. The most effective and humane way to do it is through housing, not handcuffs. Now, we need to move with urgency. We've got to move with urgency, creativity, and compassion to address encampments, because the status quo is not okay. People are living and dying every day on our streets in the throes of mental illness, addiction, medical crises, and deadly violence. 2 weeks ago, when Jordan Neely was killed on the New York City subway car, when the life was choked out of him, we saw the worst of what can happen when we dehumanize one another. When we forget that everyone we see on the streets, in a shelter, in an encampment, or on a subway train is a son, a daughter, a sister, a brother, a mother, a father, a friend. When we forget one another's humanity, we have failed as a society. But when we remember the full humanity of all those around us, we cannot help but succeed. So look around. I don't mean look around, I mean look around. Look at each other. Take a moment to recognize and remember the full humanity of the person sitting next to you. Take a moment to recognize and remember the full humanity of every single person gathered together in this room today. Look at our collective compassion. Look at our collective power. Look at the unstoppable impact of our collective work. That's right. Together, we are strong. Together, we cannot fail. Together, we will succeed in ensuring that everyone in this nation has access to the care and support they need and a safe place to call home.
Thank you so much, Jeff. I have to say, when I got the news that Jeff was appointed to his position, I literally shouted out loud. Because I knew what Jeff was about, and that meant that the administration also knew what Jeff was about, and that meant that they really wanted to see change. Jeff has been a tireless advocate for racial justice when we're talking about homeless systems, and really thrilled that that will continue to be brought to this administration, and we hope that we'll make real progress in this. Before I introduce the speaker, I also want to thank our host, Healthcare for the Homeless program, the Healthcare for the Homeless Baltimore, which has been graciously making their facilities available to us. We have site visits. I have to say, site visits for today are sold out, but you can sign up for tomorrow, for site visits tomorrow. But also, there will be a mobile health clinic van that will be parked outside. It'll be there when we finish this session, and it will be there for the remainder of the 2 main days of the conference. So really let's thank the Baltimore Healthcare for the Homeless program, all the staff, the president and CEO, Kevin Lindemood. So really grateful for them. I want to introduce our speaker, and as a staff, we go through a number of names when we are considering who we want to be for our 2 keynote speakers. And there were some names that jumped out to the very top, and Dr. Dosani was one of them. Yes. You can read his bio in the app. I'm going to read parts of it because I want to save time for us to have his full remarks. But so, as a palliative care physician in healthcare justice, Dr. Naheed Dosani is dedicated to advancing equitable access to health care for exhibiting structural vulnerabilities like poverty and homelessness. These efforts include founding the Palliative Education and Care for the Homeless, or PEACH program, at the Inner City Health Associates, serving as a health equity lead at Kensington Health in downtown Toronto, a health equity advisor at the Canadian Partnership Against Cancer, and providing palliative care at St. Michael's Hospital at Unity Health, Toronto. Dr. Dosani has received many prestigious honors for his trailblazing work. And you'll notice in the app, we spelled it the funny way with the U, for honors for his trailblazing work. These are, yes, someone got it. I was told I couldn't tell jokes. These awards include the Meritorious Service Cross for Humanitarianism from Canada's Governor General in 2018, a Humanitarian Award from the Canadian Society of Palliative Care Physicians in May 2019, the Early Career Leader Award from the Canadian Medical Association in 2020. Most recently, Dr. Dosani received an honorary doctorate, a Doctor of Laws degree from Ontario Tech University in 2022. I will say when we had preparatory conference calls for this, it was clear he could address both clinical aspects and also policy aspects as a tireless advocate for social justice and policy change. And it is a great honor for me to turn the podium over to Dr. Naheed Dosani. Thank you.
Good morning, everyone. Let's try that again. Good morning, everyone. Yes. Thank you, Bobby, for that very kind introduction. And thank you to the National Healthcare for the Homeless Council. And thank you to conference organizers. My name is Naheed Dosani, and I'm here to talk to you about living and dying on the streets towards health justice through a palliative care approach. We Canadians, like you across the United States, start our gatherings by acknowledging the sacred land which we are privileged to live and work on. As we've already acknowledged this land, Baltimore, I'd like to take a second to acknowledge the land that I work and have the privilege to live on, Toronto, Ontario, Canada, to be the traditional territories of the many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. It's now home to many diverse First Nation, Inuit, and Métis peoples. As a Canadian, I acknowledge the significant blood spilled, pain endured, and colonial violence that has been inflicted on Indigenous peoples. I come from a country where we have seen over 1,200 missing and murdered Indigenous women, where thousands of young children were massacred as part of residential schools, and where Indigenous peoples are still to this day far overly represented among people experiencing homelessness. We're deeply grateful to have this opportunity to be and work on these lands. We acknowledge this and work towards truth and reconciliation, and we're committed to partnerships, listening, and building relationships. Today, I'm really excited to achieve a few important points with you. The first, highlight the impact of homelessness on healthcare outcomes and the dire need for palliative care services within our homeless health systems. Number two, introduce innovative solutions. Yes, we'll talk about the PEACH program, but also education, advocacy, and research, and how we can inspire change for this population. And number three, through 4 lessons learned from our work in palliative care in Toronto, Canada, collectively challenge this community, everyone in this room, to bring a healthy end to homelessness once and for all. For me, the journey really begins the day that I met Terry. As a first-year resident working at the University of Toronto during my residency training program, I was working at a local men's shelter providing primary care when I was tapped on the shoulder and asked to see a gentleman. He was in crisis, he was shaking, he was writhing, he was curled up into a ball, and as I examined his mouth, I could see what was causing him so much distress. He had a cancer that had started at the base of his tongue and it had spread throughout his head and neck. He was in a pain crisis. He was in a cancer pain crisis. As I got to know him and read his chart, I actually started to learn more about him. He had been on the streets for over 15 years. He had a diagnosis of schizophrenia, and he was a person who used drugs. He was actually diagnosed with his cancer 1 year before at a local cancer center, and due to his mental illness, he wasn't able to follow up for care. And so, as time went on, the tumor grew, and he started to experience pain. So he did what anyone of us would do. He went hospital to hospital, emergency department to emergency department, urgent care center to urgent care center, walk-in clinic to walk-in clinic, seeking the kind of pain control that anybody in the United States, in Canada, or the world should have access to. Terry was denied access to medicines that would treat his pain. He was denied access to medicines that would treat his quality of life. Maybe it was the words he said. Maybe it was the words he didn't say. Maybe it was just stigma. But the bottom line is he didn't get his care, and that's why he was with us on that day. He didn't trust health workers, but he started to trust me. You know, I can be charming at times. Built that relationship with him. He promised me he'd start some paid meds the next day. I got to the shelter very early because I was very excited to help him out and work on this journey with him, and I couldn't find Terry anywhere. Terry's body was found in the early hours of the morning by a commuter on her way to work. It was too little too late. He had overdosed on a combination of alcohol and street drugs. He had turned to the best pain relief that he knew. For his street family, this was traumatic. But for me, this was also traumatic. How is it possible that in one of the world's richest cities, we could allow someone so vulnerable to fall through the cracks again and again and again and then again at the end of life? Terry's death changed my life forever, and you can't help but think how many others are out there like Terry. Terry's life and death is probably the main reason I'm here with you all today. As we move forward in this dialogue, I ask today that you think of who your Terry is. We all have at least one, and many of us have more. Someone that you knew, someone that you cared for, who died like this. I ask that you carry your version of your Terry in your heart, because I carry Terry in mine every single day, and especially on this day with you. Listen, it's 2023, and I'm fully aware that this crowd knows exactly what's going on this slide. For those who can't see it at the back, it describes the fact that over 60% of what makes us sick in our communities is based on how we live, learn, work, and play. You know these factors too well: money, housing, social networks, education, food security, etc. The kind of factors we typically call the social determinants of health. One thing that's always bothered me is that the health systems we work in are so comfortable talking about the fact that inequities in the social determinants of health exist, but are so uncomfortable talking about what drives inequities in the social determinants of health to exist to begin with. The fact that these inequities are often presented as static inequities that we cannot change or cannot modify, when in reality, if we only dug deep, we could actually identify these drivers and then modify them. So let's dig deep. For those who can't see at the back, depicted here is an apple tree by my colleague, Dr. Nanki Rai, a family physician in Toronto, who wrote an incredibly powerful report on medical violence and oppression. The apples are the products of a good healthcare system, the kinds of metrics the WHO might track: life expectancy, neonatal mortality, access to mental health. The branches are the social determinants of health. Now tell me, why is it some communities grow ripe and juicy apples and others don't? The answer lies at the roots of this apple tree, the structural determinants of health, which are driving inequities in the social determinants of health. Today, and throughout the conference, let's be sure to name these drivers: racism, capitalism, classism, ableism, xenophobia, transphobia, sexism, colonialism, and a whole host of factors that we don't usually talk about in our mainstream healthcare discourse. We here in this room have a responsibility to name these factors. We won't ever change inequities in the social determinants of health if we won't name these factors. Like many of you, I've dedicated my life to addressing these structural determinants of health, and today it pains me to report that homelessness in Canada is not just on the rise, but it continues to be grossly undercounted. For our country of about 35 million people or so, homelessness is impacting now over 263,000 Canadians per year. Sleeping rough or unsheltered is up 100%. And as mentioned before, we sadly see a disproportionate representation among Indigenous peoples and also Black people among our unhoused population. The worrisome part is that recent research shows that these numbers could be as high as 3 times more because of the way we're counting people experiencing homelessness. On the bright side, though, something is really changing among the Canadian public. 72% of Canadians, when surveyed, want an urgent end to homelessness. Maybe because 1/3 of Canadians have experienced homelessness themselves or know someone who has experienced homelessness. In contrast, reflecting on what's happening here in the United States, the federal government estimates over 1.5 million people per year experience homelessness, but I hear these figures could be twice as high, actually. The National Alliance to End Homelessness reports that historically marginalized racial and ethnic groups are often far more likely to experience homelessness. That homelessness in general is on the rise again. And while there has been some modest long-term progress in both countries, in recent years, we are seeing a homelessness crisis that is getting worse in both Canada and the United States. Thinking of Terry's tragic death today has me thinking about the many other unhoused people we've lost along the way. Were they scared? Were they worried? What were they feeling? What were they thinking? Believe it or not, this question, the preference of people experiencing homelessness as they approach end of life and their emotions, has been looked at quite a bit over the years. Probably because of the fact that without access to advanced care planning, people experiencing homelessness have a tendency to choose a more aggressive approach to care at the end of life. So what do people experiencing homelessness say about their end-of-life preferences and wishes? They do care what happens to them because they have frequent experiences of death. They want a sense of connection and community. They fear dying alone or anonymously. They care about what happens to their bodily remains. And they often choose aggressive care, ICU, intubation, CPR, because they have a mistrust of our health system. That mistrust runs so deep that they don't believe that their wishes will be matched at the end of life. The raw reality is that being unhoused is by definition meaning that at some point you will deal with seriously ill health and eventually death. Just as examples, people who experience homelessness are 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, and 4 times more likely to have cancer. Average life expectancies for unhoused people, depending on the research you read, are very low. In Canada, we often cite research that has shown that life expectancies range from 34 to 47 years old. I'm going to say that again, 34 to 47 years old. Also, when surveyed, the vast majority, over 90% of people with homes, say they want to die at home if given the chance. Our experience shows us that the vast majority of unhoused people want the same, but they don't die in their homes, their shelters, their respites, their hostels. In the places that they call home, they die in hospitals, in emergency departments, in places they don't want to be. Because we've literally designed a home healthcare system that is structurally unable to deliver care, and often palliative care, for people without homes. And the results are devastating. What does this data mean? It means that homelessness cuts a person's lifespan by 50%. When you take in all the data, literally, the social diagnosis of homelessness cuts a person's lifespan by half. While it's not how we often think of things, and I appreciate that, as a palliative care doctor, I'm here to tell you that there is no more devastating illness than the one of not having housing. Homelessness is a life-limiting illness, and it's a terminal diagnosis of the social determinants of health. This is why we must act. As many of you know, truly there's no better time to look at how a society treats its most vulnerable than when they die. Our experience shows us that as people who are homeless get closer to end of life, inequities accumulate, the gap widens. We're talking about people who are both in need of palliative care services and experiencing deficits in the social determinants of health, and as a consequence, live with complex, intersecting health and social concerns. This double vulnerability brings home the point that death is most certainly a social justice issue. So in 2014, my colleagues at the Inner City Health Associates in Toronto, Canada, decided to make a change. We knew we had to do better to meet the palliative care needs of unhoused people. We knew we needed a model that was built off the best practices already developed in programs like the ones you guys all work in, including case management, access to primary and mental health care, interprofessional care, care across settings, learning and leading with lived experience, and integration with the housing sector. At the same time, we recognized the concept of modern progressive hospice palliative care was missing in many of our homeless health systems around the world. For those who are new to it, palliative care is both an approach and a specialty. that aims to provide quality of life care for people with serious, life-limiting disease right from the time of diagnosis. Palliative care is a human right. It's an approach to helping people with life-limiting disease. While it gets focused on the end-of-life aspect of care, it's not just that. The palliative care journey actually starts right at the time of diagnosis. It focuses on quality of life, and while it affirms life, it understands death as part of each person's journey. Palliative care is active treatment. It's not doing nothing. It involves the client and their street family. It's for any person at any stage, at any phase of illness, and can be provided in any setting: a shelter, the street, a home, a hospice, a long-term care facility, or a hospital. It's a philosophy. It's a way of doing things. And most certainly, it's a tool. It's a plan for the future. Just a word to avoid confusion about our two countries. Hospice for us in Canada generally means an inpatient place to go for end of life, whereas here in the United States, I understand hospice is described as a program where you can get care in many places, which typically features no life-prolonging measures for a limited life expectancy. And like many parts of our healthcare systems, when it comes to palliative care access, we see a social gradient that exists. The number one determinant of palliative care access across the United States, Canada, and typically OECD countries is your postal code, which is basically a surrogate for your income. Unequal lives equal unequal deaths. And so, on July 1, 2014, the PEACH program, Palliative Education and Care for the Homeless, was born. Canada's first mobile, street and shelter-based palliative care program aiming to provide health care to people experiencing homelessness with life-limiting illness, so that no person would have to die alone or ever fall through the cracks, whether on the street, in a shelter, or under a bridge. The program started at the back of my Honda Civic, working one day a week. No joke, I literally started this at the back of my Honda Civic. We just got rid of the Civic recently. With my colleague, Nurse Namrig Ahmed, and I driving around the streets. And fast forward to 2023, PEACH has grown to become one of the largest community-based palliative care programs for people experiencing homelessness in the world. Our team today features a nurse coordinator. Thank you. Our team includes a nurse coordinator, home care coordinator, social work health navigator, 6 hospice palliative care doctors, a PEACH psychiatrist, and an interprofessional roster of home care professionals working in non-traditional home environments. We've cared for over 1,000 clients since our birth, carry between 110 and 120 clients on caseload at any given time, and also after a one-year retrospective chart review, we found that 64% of PEACH clients never went to the hospital or emergency department, 80% of PEACH clients died exactly where they wanted to be, and 83% were reconnected to family or friends if they wanted to be. In 2016, the University of Toronto named PEACH as a best practice in social accountability in healthcare, and has since created a formal partnership where every graduating palliative care doctor from the University of Toronto must rotate with us as part of a mandatory learning experience, and they love it. In 2018, PEACH was named by the Government of Canada as a best practice in palliative care equity in the palliative care framework. I'll talk more about this later. And finally, more recently, the PEACH program was recognized by the Governor General of Canada as a trailblazing practice in palliative care. I just want to shout out my colleagues, Dr. Donna Spanner and Trevor Morey. Can you put your hands up wherever you are? Yeah. These are my 2 PEACH teammates. We'll be giving a workshop tomorrow. You two are rock stars. PEACH works because of our commitment to core values. Harm reduction. Yeah, we prescribe opioids to people who use drugs so we can treat their pain. Trauma-informed care. We care for many people who shouldn't be dying, but are dying because healthcare has traumatized them, and that's why they didn't access care to begin with. An anti-oppressive approach to care. We're not here to top-down deliver health resources. We're here to redistribute health resources to the people in an equitable way, and an interprofessional approach to care. We do not negotiate on these values and never have since our birth. For those familiar with clinical practice in palliative care and palliative medicine, we go way further. Yes, we provide a palliative approach to symptom management, but as mentioned, we train the next generation. We advocate for a healthy end to homelessness. We conduct advocacy-based research to give this work the credibility it deserves. And finally, like many of you, we're social prescribers. It's not enough to treat the pain, nausea, and constipation. We prescribe housing, we prescribe income, and assist with things like healthcare navigation, even supporting our clients to get to appointments by supporting transportation and appointment accompaniments. In truth, the PEACH program works because we strive to integrate social and health services. Like many of you, bring a trauma-informed approach to care to our discipline, see harm reduction as fundamental, and are flexible and agile to meet people where they're at. We start from a place where we recognize the people we care for, this health system was never designed for them. Actually, the system isn't broken. It was literally built this way to exclude the people we care for. That framing is everything. Today I'm remembering the many people our PEACH team has cared for over the years. Pandora was a young, energetic, creative, and charismatic woman who in her 20s faced physical and sexual violence while growing up due to a family member. She ended up on the streets where she fell into a life of drugs. Unfortunately, she was diagnosed with infectious endocarditis and ended up in a large surgery center where she was denied access to potentially life-extending heart valve surgery because she was a person who used drugs, even though there was no research to show that she would fare poorer in the surgery because she was a person who used drugs. Pandora was discharged to the street without oxygen to breathe, medications to treat her pain, and without a stable roof over her head. Our PEACH team met her, built a relationship, treated her pain, and even at her request to lead with lived experience, worked with the CBC, our national media broadcaster, to help produce a documentary on her story on our national news show, CBC News, The National. Tragically, 4 days into filming, Pandora died of an opioid overdose death. The documentary's direction changed into one that focused on the ripple effect that her death had on our PEACH team and her street family. I often reflect on the fact that I feel that stigma ultimately is what killed Pandora. Pandora is a constant reminder that the stigma our patients face by the mainstream health system is not a frivolous matter. It's literally a matter of life and death. Archie was an elderly man who fell homeless for the first time at the age of 67. He was a homeowner, an engineer, and due to an unfortunate sequence of events, became homeless. One day, he was at a bus stop and started to have abdominal pain and vomiting. He was rushed to a hospital where he was diagnosed with terminal cholangiocarcinoma. He was discharged to a local men's shelter where our PEACH team got to meet him and care for him until end of life. His only last wish was that he wanted to die in what he now called home, this shelter where he participated in a managed alcohol program. He said, if you really want to care for me, then meet me where I'm at. I've lived a traumatic, hard life. I've found peace at this shelter. Let me die in peace in my new home. And so our PEACH team did all we could to care for him there, trained shelter staff to support end-of-life care, support his pain, bring in extra home care supports, and even conducted medical visits with his consent in the park so that he could spend the time he had left doing the things that he loved, which was the daily crossword puzzle. Archie died in his new home, the shelter, I suspect with the peace he desired. We must always remember to acknowledge the full dignity of each person beyond the stigma of their marginalization. We at PEACH are super proud to be part of what is now a national and international family of teams and programs who created PEACH-like models in many communities. On this slide, I note two of our sibling programs, the Calgary Allied Mobile Palliative Program in Calgary, Alberta, and also the Palliative Outreach Team in Victoria, British Columbia. What is so exciting is that the PEACH model of care is now the standard of care in cities like Edmonton, Montreal, Brampton, places in Australia, the United Kingdom, and after the conversations I've been having at this conference, I have a feeling we'll be seeing more models across the United States as well. If anyone is interested in learning more about the intersection of homelessness and palliative care, this report is a must-read. It's entitled Too Little Too Late, How We Fail Vulnerable Canadians as They Die and What to Do About It. It's important because it's the world's first research study following people experiencing homelessness with palliative care needs from diagnosis to death. The study, led by Dr. Kelly Stadge-Dahar at the University of Victoria, took place in Victoria, British Columbia. It utilized ethnographic research, over 300 hours of observation following the experiences of 25 unhoused people as they struggled to access the palliative care they need. What did they see? The idea that, honestly, palliative care is often seen as a luxury or bells and whistles because people are just trying to survive. Number two, that it's really hard to talk about death when death is so common for people experiencing homelessness in their communities. Number three, when people are so ill, where do you start? It's hard to know who to initiate a palliative care approach with. Number four, people experiencing homelessness have to go here for your food, there for your money, there for your medical care. Too many silos, we need to break them down. Number five, even when home healthcare professionals wanted to go above and beyond, their employers would not allow them around barriers particularly related to workers' insurance. Number six, there's a bereaved community out there, and I'll talk more about this later. And number seven, when there was a health worker, it could have been any discipline, who understood homelessness and the social determinants, but also understood a palliative approach, incredible things happened. People got the care they needed, when they needed it, where they needed it, how they needed it, and it just showed that there was justice for some. We never could have imagined for 1 second that our work with Peach would one day be written into a national document like this one, Canada's Framework on Palliative Care, detailing our country's blueprint for palliative care development. By being named a best practice, Peach and our advocacy has been etched in the minds of policymakers, but more importantly, critical funding is now being allocated for this work. On a broader scale, the Peach team works with communities internationally, not just locally, to really spread the work through global health. We're part of a pan-Canadian research collaborative called Equity and Palliative Approaches to Care, www.equityandpalliativecare.com, led by Dr. Stadge-Dahar at the University of Victoria. This group puts out incredible research and work. Check it out. We joined with the Coalition to Transform Advanced Care based in Washington, D.C. to put out some educational content and also create a community of practice. And finally, we've promoted this work alongside incredible clinicians and scholars like Dr. Caroline Shulman and Briony Hudson from London, England, who've created this amazing online free open access textbook called www.homelesspalliativecare.com. Please do check it out. So what have we learned through Peach? We've learned that the model works, that palliative care should be a necessary element of any homeless healthcare system, that an over-reliance on specialized programs like Peach has the potential to lead to de-skilling in our mainstream healthcare systems, that mainstream healthcare systems are keen to learn from us, and we really should be working with them, but more on this in a bit. And number five, for homeless health providers, the provision of palliative care has served as an antidote to moral injury, compassion fatigue, and burnout. But I think it's important that we work together to zoom out and really see the big picture. As we move towards the latter portion of today's talk, I recognize that not everyone in this room will work in palliative care, but also recognize that through the provision of palliative care over the last 9 years, our team has learned a lot. So today, I humbly offer 4 lessons learned from our work on the streets of Toronto to collectively challenge this community, our community. So here goes, 4 lessons that our Peach team have learned to bring a healthy end to homelessness. Number 1, our work is the advocacy. As a Peach provider, there's no doubt that we sit downstream in the life trajectory, but there's no greater time to better understand how structural inequities lead to poor health and eventually death than being downstream to see it. My message to you is that we at Peach are often providing palliative care for people who just should not even be dying, or would not be dying if they didn't have to deal with poverty, homelessness, systemic racism, discrimination, and oppression. Take it from us, we see the sequelae of all this downstream at the end of life. Your advocacy upstream is important. You can save lives. Collectively, we must see ourselves as part of these broader movements to end homelessness. And while I know so many of us focus on our day-to-day work, the big picture, that's the moral responsibility work. That's the social accountability work. Sure, providing care right now on the front lines is what's needed, but being part of those larger social justice movements, that's where it's at. Some key questions I ask you to ponder as we move through this conference and into the next day and into the next. How are we using our credibility as health workers to improve care for people that we care for? to shape public policy, to get people to value dignity of life for an often stigmatized population? How are we using our privilege as clinicians, for the clinicians in the crowd, to elevate the issues and experiences impacting people experiencing homelessness for this often overlooked and silenced population? We must see this as our mission. Advocacy is the mission. And while some may think more advocacy will lead to burnout, what we've learned is that advocacy in any form is a potent antidote to burnout and moral injury. We must challenge the mainstream health systems that our clients interact with, because if we don't, they will face systemic racism. As a Canadian, this is something that we're talking a lot about right now. Brian Sinclair, depicted on the left, was a middle-aged Indigenous man from Winnipeg, Manitoba, Canada, who presented to an emergency department for care. Over a 34-hour period, he was left unattended, untreated, and ultimately died from a urinary tract infection. His death sparked an uproar across Canada and even led to a book being written about the whole tragedy called Structures of Indifference. And it's a classic example of how systemic racism is killing people in mainstream healthcare. Joyce Echequan was a woman who was literally dying in a Quebec hospital. Quebec is a province in Canada. As she was dying, her health workers literally were throwing racial epithets and slurs at her. She turned on her Facebook Live and recorded it. She died, and the only reason we're talking about her is because she recorded it. How many others have suffered like Joyce, weren't able to turn their cameras on, and how many others have suffered due to not just overt forms of racism, but covert forms of racism? We have a responsibility to advocate for a health system where we name anti-racism and act on it, where anti-racism training is standard for health workers, where race-based data isn't just collected for the sake of it, but it's acted upon. We must challenge the cities and governments that continue to oppress and discriminate people who live in encampments. Like many cities across the United States, Toronto has seen a significant uptick in state-led violent encampment clearings over the past few years. These photos, which have now gone viral worldwide because of how gruesome they are very real depictions of the state-led violence that has been sanctioned by our City of Toronto over the past few years in response to encampments. In fact, the City of Toronto has spent millions of dollars on policing and enforcement to violently displace people experiencing homelessness. I know many cities across America have been doing that as well. So let me get this straight. Encampment residents live in a city where they're not provided safe spaces to live and then are violently being displaced because they do not have a safe space to live? Let me get this straight. They've got money to displace people, but not to house people? Come on. We must speak out against the inhumane and voluntary displacement of people who experience unsheltered homelessness. Not just because it's the right thing to do, because the scientific evidence shows that it's an ineffective approach. This study, published in April in JAMA, shows that encampment sweeps, bans, move-along orders, and cleanups that forcibly relocate individuals away from essential services will lead to substantial increases in overdose deaths, hospitalizations, life-threatening infections, plus many other detrimental impacts. We have a responsibility to speak out. Our voice is vital. Number two, we need to build capacity by engaging mainstream healthcare systems and the government. What we've learned through PEACH is that an important tension exists in this work, the need to develop specialized models of care, like PEACH, versus building capacity in the broader systems around us. Why is this important? Because there isn't enough of us to go around, and there probably aren't enough resources available to help every unhoused person through homelessness budgets in Canada and the United States. To just focus on our specialized carve-outs in our cities would not solve these issues long-term. Two things can be true at the same time. We can develop specialized models of care like PEACH, but we can also see the big picture and work with our broader health movements and governments to raise the bar on equitable care. Our activism must include partnering, supporting, and building systems that connect with the mainstream. I'm proud of what we've done through PEACH, but I gotta be honest, it's a sad state of affairs that we needed to create a PEACH program to begin with. Perhaps that's a sign that we need to see ourselves also focused on building capacity. One meso-level intervention in my personal life associated with this in my journey is the fact that more recently I've been appointed as the medical director of Toronto's largest hospice, Kensington Hospice. If you told me just a couple years ago that I'd end up becoming the medical director of a mainstream, yet prestigious and nationally renowned 19-bed facility, I would have laughed at you. When I was hired, I was given the mission by hospice leadership to make the hospice more equitable, because leadership was recognizing it was becoming inequitable. That the data showed there was a tendency to serve rich, housed, and mostly white people. While Canada is lucky to have universal health care, our universal health care system focused mostly on physician and hospital services, so you still see these inequities exist in mainstream care. So why did I take on this role? Because I realized that, like you, I have a responsibility to work within the mainstream to make that change. How did we do that? We implemented health equity training for all workers at the hospice, totally redesigned our data collection to collect social determinants data. We hired a homeless health navigator. We partnered with homeless health community providers, and even recently hired a peer worker with lived expertise. The result, a significant increase in the proportion of people who experience homelessness, who have mental illness, who are racialized, experiencing poverty, and non-English speaking. While it remains a work in progress, it is working. I also want to give a shout out to my colleagues from St. Michael's Hospital, Toronto, Dr. Stephen Wang, Alyssa, Fred, Kate, the whole team is here. They run this incredible program at St. Michael's Hospital where they have homeless health navigators in the hospital who are facilitating and coordinating transitions of care from the inpatient side to the community. Our talents and skills can make mainstream healthcare more equitable too. At the macro level, a good example is the recent announcement by Health Canada to make a lot of money available for palliative care for people experiencing homelessness. This announcement was the result of a lot of advocacy, and over the next 4 years, we'll see 20 projects, 10 of which are depicted on the slide, which will specifically fund palliative care for people experiencing homelessness in cities across Canada. As the co-chair of this initiative, I could not be more proud of our team and advocates across Canada who are looking at the big picture. So here's an avocado. You know, I thought apple tree, peaches, avocado, we got it all, right? The avocado framework is a framework that describes social accountability designed by our colleague Dr. Sandy Buckman, who's part of the Peach family and former Canadian Medical Association president. It's a reminder of our role in all this. Some of us will work effectively throughout our careers at the micro level, caring for the people we serve. Some of us will work at the meso level, deriving solutions in our neighborhoods and local communities, maybe like Peach. Some of us will work at the macro level, deriving solutions about the broader realm of policies that impact at a public health or population level. Some of us will work at one level our whole life. Some of us will work at all three. Some of us will fluctuate. To be truly socially accountable, we need you all. Number 3, we must create space and resources available for people with lived experiences, actually expertise, to lead. And we cannot tokenize this process. We must create infrastructure to support people with lived expertise. We have to ask ourselves, how do we support these folks, and what supports are needed? We also have to make sure that equitable groups are represented among people with lived expertise. We at Peach have learned this cannot be just a check-the-box kind of process. This has to be about authentic engagement. How do we do that? Through co-design. I truly think that co-design should be a best practice that should be standardized. Listen, this number 3, this is the conference theme for a reason, because it's so important. I want us all to give a round of applause to the National Consumer Advisory Board, who celebrates their 20-year anniversary. And as I close out today's session, number 4, to push this movement forward, we're going to need to care for each other better, and that will mean we will need to grieve together. As I look out today at all of you, I cannot imagine the suffering you see day in and day out. We literally work in systems that do not care for the people we serve, so we abut against system failures all day long. What does this create? A recipe, a perfect storm for that compassion fatigue and burnout. How many of us have found people dead or not known that someone was dead? This work is not easy. This work stays with you. These experiences stay with you. To push this movement forward, we're going to have to spend more time and resources inspiring wellness in us. It's essential that our homeless health systems incorporate additional support for staff. And I'm not talking about pizza lunches. Don't get me wrong, I like pizza. It's actually my favorite food. So while pizza can be awesome, I'm talking about what we really need. Structured supports for us to address our moral injury and compassion fatigue. It's something I spend a lot of time thinking about as a Peach team member, maybe because we work in hospice palliative care and we see this a lot, but because health and social care workers working in the homelessness sector, you do not get enough support around your grief. How do we as a community hold ritual and acknowledge mourning and passing? Tracking homeless deaths is important. It's an important component, but how do we honor the dead? People think that grief slowly gets smaller with time. In reality, grief stays the same size, but slowly life begins to grow bigger around it. That's why since the birth of the Peach program, we've held grief circles to support the health and social care workers who do this hard work. You see, whenever a Peach client dies, we descend on the shelter, respite, drop-in, wherever it is, and we form a circle. We light a candle, we hold a minute of silence, and then we cry together. We laugh together. We remember what it was like to care for the person. We reflect on what it was like to care for them. And then we think about ways that we can renew and reinvest in each other. We call it the 4 R's. We hold another minute of silence, we blow that candle out, and we know we leave that grief circle, we'll sadly be back again in a grief circle too soon. Grief circles have become central to the culture of our compassionate Peach community. They've allowed workers to feel, to grieve, to express their pain, and do it in a space where they feel safe. As I reflect on our Peach circles, grief circles, I wonder why it just isn't the norm in our homeless health systems to talk about grief, or even just generally in healthcare. While I know that grief circles are just scratching the surface in our little corner of the world, they're a start of a culture change that we need in healthcare, in our homeless health systems. To support each other, we need to grieve together. That's why since 2014, we've also offered the Good Wishes program, a psychosocial intervention that provides special gifts for terminally ill patients cared for by Peach. It's anything from tickets to a hockey game, to a nice dinner, to, in Richard's case, a man experiencing homelessness who was cared for by Peach, who was dying of lymphoma, some art supplies, because he was a soap sculptor. For our Peach clinicians, the Good Wishes Project has been a potent antidote to moral injury and burnout because it allows our health workers to address the total pain and suffering they are seeing in a meaningful way. On the 3rd Tuesday of every month, advocates and people with lived expertise gather at the Toronto Homeless Memorial in the downtown core and read out the names of those who died. The ceremony now live streams online so more people can join. We are living amidst immense tragedy and witnessing immense suffering, but we are building community around it, and we are healing as a result of it. In summary, here are the 4 lessons that Peach has taught us to bring a healthy end to homelessness. Number 1, our work is the advocacy. Number 2, we need to build capacity in our mainstream systems. Number 3, we need to support space and resources for people with lived expertise. And number 4, we need to care for each other better, and we need to grieve together. As I now reflect on nearly a decade of work by the Peach program and our collective work across Canada and around the world, I reflect on the fact that it's about trauma-informed care, which especially means we have a duty to stay humble, give people choice, relinquish power, make people feel safe, and center our care around compassion. It's about meeting people where they're at, not just physically in non-traditional health spaces, as many of you do every day, but emotionally, holistically, and spiritually. I know you know what I mean. It's about centering our values on our values like harm reduction and not wavering from those values. Our values are foundationally oriented in justice, and our values are non-negotiable. It's about moving from equality-based healthcare, where people get the same things to be happy and healthy, to equity-based healthcare, where people get what they need to be happy and healthy, to justice-based healthcare, where people get the resources they want and barriers are removed so people can choose what makes them happy and healthy. It's about compassion, and hopefully we've seen today that a palliative approach to care is probably closer to what you do every day than you might have originally thought, and that it can mean the world to people. I hope the palliative care approach that I've reflected on these last few minutes with you can inspire hope at times of hopelessness, empower us at times of scarce resources, and can lift us up in times of deep loss, trauma, and grief. In conclusion, I want to thank you for having me. My deep gratitude goes out to the entire National Healthcare for the Homeless Council, the organizing committee, and to each and every one of you who do this hard work every day. Gratitude to the many organizations, thank you, who support this work. And finally, I just want to say one more thing. On Friday, coming to this conference, the City of Toronto declared homelessness an emergency. You can look it up, it's all over the news. Someone asked me, do you have hope? And I said, yes, there is hope. But with this announcement, what I will say is the rhetoric has to stop. The words has to stop. The talking has to stop. Now we need action. So if you remember the apple tree, let's dig deep at the roots of injustice and let's actually make the kind of change that we really hope for in this society. Thank you very much.
Wow. We watched a YouTube video before selecting. This was so much better in person. We're so glad that you can be here with us. There's so much to say. I just want to point out that we will be calling on Dr. Dosani to help us in our efforts towards equity. One of the things you may not have noticed, but in the JAMA article that was on the screen, the council was actually a really essential part of that came out of our mortality work group, working with the University of New Mexico researchers with CDC, and two of our directors, Dr. Elena Boyer and Dr. Courtney Platson, are among the authors of that study. It's gotten a lot of notice, so again, we just want to focus on how we can affect public policy through what we're learning at the clinical level to make this a more just society so that we can stop encampment suites without giving people the resources for that. Also, we have been engaged in a work around equitable palliative care practices focused on substance use disorders. That was a partnership with CDC and the National Association of Community Health Centers, and we just got word that will be extended. So we will definitely be calling upon the expertise in this room and also you, Dr. Dosani. So a few quick notices before we leave. Want to say we have a full day of, and we have a full house. So when you are going to your sessions, please have a backup ready. We have to honor the fire code, and we have some space set aside for those with, who have issues with mobility, so we want to make sure that we are making it easy for them. So please respect the space, and if you're asked to to go to another workshop, please have another one ready. We want you to practice self-care. So masking is recommended, but not required. So if you feel you would like to mask, please do. Also, want to encourage you to hydrate, to take breaks as you need. Use the recharge room. Follow the signs near the elevators to guide you to the water view rooms. We want to make sure everyone knows about this conference, so please put your pictures on social media. Use the hashtag HCH 2023. And just have a great time. We have no programming during lunch, so this can be a great time for you to network with friends, connect with friends. In the app, you can reach out to people, say, hey, let's meet up such and such a place. If you want to disable that feature, you can. But this is a great time to network. We're just so grateful for those who have made this possible. Thank you again for Baltimore HCH. We're told that the van is out there. And please have a great day. Go out, learn, and come back and go home to serve. Thank you, Dr. Dosani.